please be on standby. We are live. Ma'am, we are live.
A very good afternoon to all of you who are listening to this ECMO workshop held on the 25th of April 2021, jointly brought to you by ISA Delhi and NCR and the Simulation Society. It is my proud privilege to organize this as a scientific chairperson and also to work in tandem with experts on ECMO throughout the country who are national and international figures who are here with us throughout the day to give you your insights into a beautiful modality for the failing heart and the failing lungs, the extracorporeal membrane oxygenation. When you have a patient dying on ECMO because of sepsis, there is also sometimes and very often a lack of ECMO nutrition. And that is the reason we have with us none other than Dr. Yatin Mehta. I would call him the father of critical care in the country. He brought about robust changes in his ICU at Medanta, the Medicity, and has been a pioneer trying to overcome the COVID pandemic. And in the largest hospital, private hospital, which dealt with COVID in a very deft manner, Dr. Mehta also stands tall as the presidents and founder presidents of not just the IACTA, the ISCCM, but also the reigning president of SWAC ELSO, the Southwest Asian branch of ELSO. So here we are to introduce our panelists. I give the mic over and have a very good hearing on ECMO for nutrition and sepsis in the hands of experts. Over to you, Dr. Mehta.
Thank you, Professor Murali. Thank you, everybody, for being there. And we have a very illustrious faculty, the panelists, for this session. We have Dr. K. Muralidhar. He's a professor and head of critical care in cardiac critical care in cardiac anesthesia at Narayan Hrudayalaya in Bangalore. He's been a past president of IACTA. Then we have Dr. Naman Shastri. He's the head of cardiac anesthesia and critical care at Epic Hospital, Ahmedabad. Also is a board certified for echo. Then we have Dr. Yash Javeri. He is the head of critical care at Regency Hospital in Lucknow and a close associate of mine. We have Arpan Chakraborty. Arpan is leading ECMO guy. He's the president of the ECMO Society of India, and he has saved many, many lives with ECMO this COVID season. And we have Dr. Sambit Sahoo. I can't see him. He's yet to join. He's the head of critical care at KIMS Hospital, Bhubaneswar. And last but not the least, we have Dr. Murali Krishna. He's a senior consultant at MGM Hospital in Chennai. MGM does a large number of heart and LVADs and heart transplants and lung transplants. So it's a pleasure being here. What we are going to discuss is a relatively ignored part of ECMO. Most of the times when you talk about ECMO, you talk about the devices, you talk about indications, contraindications, how long leave it in, what are the studies, but there is very little on what we are going to discuss in the next half an hour or so. Nutrition and sepsis. Everyone just presumes that yes, they can get sepsis, but nobody seems to know how to handle it or how to prevent it. So I'll roll the ball with the Arpan. Arpan, what is the incidence first of incidence of sepsis in patients on ECMO, And what is the prevalence of hospital-acquired infections in these patients?
Actually, to talk on sepsis on ECMO, it should be divided into two eras. It's before COVID and after COVID. We used to talk when sepsis on ECMO before COVID. It was the measured amount. It was 10 to 30%. If you take it, it sometimes it goes up to 30, even 60% in different centers. But if you take as in sepsis COVID ECMOs, it has gone up to more than last out of the Chile when there are 85 cases they have reported. Other indications were almost 80%. And we are with this in our group of data is also almost showing the same kind of incidence of infective things in COVID ECMOs. So largely it is in between. If we tally, it's coming variable from 10% to 80% almost. But the thing is, if you see what is actually giving these varying kind of sepsis data, it is mainly prudent on the basis of the duration of the ECMO. In cardiac ECMOs, in venous, in long respiratory ECMOs, that different. So if you see a patient who is coming out within 7 days of ECMO, his chance of getting infected is only 9 to 10%. It's the same guy who is staying on ECMO for 2 weeks. It goes up to 27%. And if more than it goes, can be up to 64%. So usually the duration of ECMO is mainly causing the and obviously there's a much more chance of infection than the pediatric patients. And the VA ECMO much more. You have other device in
The risk factors will come to that. And HAIs, what are they? Most of these are HAIs, I suppose.
Yes, sir. HAI, it has been reported is around 24%, 27%, 28%. But grossly, if you see in even in COVID data, we have seen it has gone more than 50% sometimes. Starting from this VAP to CRBSI to where the least is the UTI. On the VAP, if you calculate it, it is coming around 30% in case of COVID.
COVID patients, CRBSI and VAP is quite high
Is
as such. And on top of that, ECMO, I think, is an additional risk factor for these patients.
for this patient.
Yash, you have been dealing also with these COVID patients. And so what are the implications? Once your patient is septic on ECMO, what does it mean? What difference it makes?
Sir, sepsis increases mortality in ECMO patient. Often it becomes the last nail in the already worst outcomes in ECMO patients. It has been demonstrated that it is a bad prognostic sign and an independent negative predictor of mortality for patients who are already on ECMO. And many of these patients are waiting for a transplant or for a circulatory assist device. Having an active infection which is causing sepsis further worsens the chances of a good outcome with that particular procedure also. And it is very difficult to differentiate SARS from sepsis, and often sepsis is diagnosed late in patients on ECMO. So it is a double whammy for patients who have already been compromised in terms of hemodynamics or oxygenation indices to have sepsis.
Also, that means not only the mortality goes up, Yash, but patients, if they get sepsis, septic while on ECMO, their organ support is going to be required more. They are going to stay in the ICU for longer. They'll stay in the hospital for longer, and they'll have longer prolonged illness even after discharge. Recovery time will be much longer, even at home. I think they're going to, and obviously there are significant financial implications in these bad times when everyone is hit hard with the economy going down. The private hospitals, their bills will significantly go up. The antibiotic administration will go up. The drug-resistant sepsis will go up. And the other things happen because of that. So, Dr. Muralidhar, so what are the risks? That brings me to what are the risk factors for getting a patient to get infected while on ECMO? Some of this Arpan is already covered, but we can repeat that again.
Thank you. Is up to 30%. If it is less than 1 week, it is up to 6%. It also depends on the risk of infection in neonatal is expected as compared to population, and also presence of congenital disease, especially immunocompromised risk of infection in patients who are on ECMO. Did you point?
Not that clear. So longer the ECMO, longer the chances of sepsis. 6% within a week, and then it increases to almost 30% as time goes by, more than 15 days. VA ECMO has more possibility of sepsis than VV ECMO. Children are less likely to get septic compared to adults. And surprisingly, one study has shown that the dual lumen cannula has more chances of sepsis, but that was that was only in one study because there is no logic to it. I see no reason why that should happen. And I would think, but that more the transfusions, more the chances of sepsis. As the patient requires more blood and blood products, the chances of sepsis will definitely increase. Also, it depends on how you have put the ECMO. I mean, is it ECPR? If you put it in emergency situation, the incidence is much higher than you put it under a controlled situation. So these are the factors which will probably affect what the patient gets. My other question to Muralidhar was, what are the common organisms of patient who get sepsis? Dr. Muralidhar can join in as soon as his connectivity is approved. So if any of would like to say, yeah, then you're welcome to say. Yeah. Common organisms.
Major, in the risk factors, what you mentioned, sir, one of the major thing is the nutritional depletion. We see that once they start going for a nutritional depletion, the chance of getting the infection is much higher. For a same patient, if they're well maintained in terms of nutrition and their muscle, everything, they do well. And the common organisms seen in most of the places, it's gram negative. That's what we see in India, though it is gram positive is reported in the Western societies. It's a gram negative, and if someone for a prolonged time with prolonged lines, and if they are depleted, that's when you start seeing the fungal infections in these kind of patients.
Correct. See, in the West, it is cons. So we must keep cons in mind. Cocal is negative Staph aureus. And in the Indian subcontinent, obviously, it is gram negative, which is more common. In the government hospitals, probably Pseudomonas will get commoner. As the duration increases, Pseudomonas is also commoner. And fungal sepsis happens. Candidemia would be the commonest thing to happen in these patients. So that one, and obviously then MRSA follows. The patient is hospitalized for a longer period of time. So you must think about gram positive as well as gram negative sepsis, and after a period, maybe keep fungus in mind. So that is what it is. The common organisms. So Naman, once these patients would be septic, you will put them on antibiotics, I suppose. So what are the PK issues? Because obviously there is a dilution, there is a pump run. So what are the pharmacokinetic issues which one has to keep that in mind?
Yeah, good afternoon, sir. Yeah, there is a lot of issues because this is a challenging case. Because of studies, there are inadequate studies we have, and the studies are extrapolated from the patients having the condition of ECMO or some neonatal studies. So they are not very clear studies except a few antibiotics which have shown the clear-cut development many of the times for the TDM, therapeutic dose monitoring way, but that is not possible in most of the where patients have been put on the ECMO. Another important thing that when the patient is already on the ECMO, number one is they are having the multi-organ dysfunctions, and the patients are having more than one medication going. We are antimicrobials, sedatives, hypnotic, coagulations, vasopressors, and vasoactive agents. But the problem here is as compared to the like sedatives and vasopressors, where we can titrate the drug while the patient's clinical. Here in antimicrobials, it is not possible to titrate the dose once we start the patients on this antimicrobial. So definitely there is big concern for this PKPD values for the patient on whom we put it. Basically, there are the three important factors which play the role. One important factor is the sequestrations of the tubing. So the tubing factors, the drug factor, the physiochemical properties of the drug, and the third is, and that is one most important, is the clearance of the drug. If we look at this, the sequestration, like if you look at the tubing part, the ECMO circuits related things are, it is the one more important is the sequestration of the drugs. Like the drug circuit, the ECMO circuits work as a reservoir. So sometimes many of the antibiotics which are having variable protein binding capacities, hydrophilic drugs or lipophilic drugs, they have some tendency to bind to the and adsorb to the circuits. It is not only that issue, but over a period of time, these absorption they start releasing into the circuit, and then the drug overdose system starts. So at some stage, we have to stop or reduce the dose of the drugs, and so that is very important. So some antibiotics are responsible. Second is the dilution of the drugs. Like when we are priming, suddenly there is a dilution, a lot of dilution drugs, and certain antibiotics they have the direct influence of the dilution. And the clearing of the drugs, like the patient having the hypoxemia or hypoperfusion to the major organs like the liver and kidneys, and the patient may have the hypoxemia, and that leads to also the clearance issue. At the same time, when these patients are being given the large volume and vasopressor drugs, then these patients have the high cardiac output. Now, say the drug sequestration. Important components of the drug sequestration depends upon the age, how old is it, which priming solution has been used. That is again very important. And the third is the physiochemical properties of the drug. So in sequestrations like certain antibiotics, they absorb much faster as compared to the other antibiotics. And the most important thing is, apart from the type of oxygen, also plays a very significant role in this. Now, if you look at the physiochemical properties, there are two important properties which play a role in hydrophilic capacities of the drugs and lipophilic capacities of the drug. So if we see the lipophilic capacities, there is a protein binding side. Protein binding is very important thing, and there are the group of drugs which a lot of variability in the protein binding. Say, for example, beta-lactams. So in beta-lactam, in the same group, there is a lot of variability into the protein binding into the different drugs. So the hydrophilic capacity, the capacities of the drug is measured in the log P values. And if the log P values or lipophilic capacity is high, these drugs are sequestrated and adhered to the tubings very high. Second important thing is the hydrophilic capacities. Now, when we put the patient on the ECMO, the systemic inflammatory response, they start into it, and then there's a lot of changes in the fluid compartment of the drug, and that leads to a lot of changes in the dilution and the inflammation and the hyperphilicity. Even though patients are put on the ECMO, the pH of the drugs also keep on changing. So physiochemical properties are also very important into consideration of the drug. And there are some antimicrobials. Now, if honestly I say there are drugs which we change into our practice according to the data, but some important antimicrobial, that's what I come later on, which has got a direct impact on the ECMO and the PKPD values.
Very nicely written, Naman. Thank you very much. So I think one has to keep that in mind that the volume of distribution is also increased. And initially, once the patient is put on ECMO, eGFR, if it is increased, the clearance also would be increased. So that both the things can affect the level of the drugs. And unfortunately, in India, we do not have therapeutic drug monitoring easily available. So that is also a problem. Coming to some specific antibiotics, Naman, would you like to say common antibiotics which you use, what happens to them and how should you use them?
Yes, sir. Actually, as I said, the sequestration plays a very important role, and there are some conflicting evidence of the studies which has shown that some studies shown that okay, this drug is going to be sequestrated nearly 75 to 80%, and some study has shown that okay, it is that bad. So there are some controversies lies in some drugs, but if I had one of the important few drugs that are using nearly 60 to 70% per package, and these drugs that in our case we use nearly 60 to 70% of the drugs. Now, in beta-lactams group, if we the commonest drugs that we use in cardiac surgeries, it is the ciprofloxacin. Now, the ceftriaxone drugs which has got 85 to say 70 to 85% absorption capacities, and we know that in beta-lactams to be a more bactericidal effect, we need a 3 to 4 times of the MIC value as compared to the other drugs. So these drugs, particularly ceftriaxone, we start sequestrated, and this keeps on doing for 4 days, and after that these drugs start releasing inside the tubing inside the blood, and the toxicity drugs started. So, but in another recent study, they have shown that still this is not bad, and to use the ceftriaxone we can use easily. So there are some variable data for beta-lactams, but if you, I just give you my own data, I would say that we are using ceftriaxone very common, but whenever we use more than 1.5 times of the creatine clearance. Another drug is like if you say the aminoglycosides. Even aminoglycosides, a lot of studies have suggested that you should go with the therapeutic dose monitoring, but as you said correctly, that it is not widely available because it has got directly impact more than drug sequestration. It has got mildly more effect on the dilution of the drugs. Of course, we try to avoid aminoglycosides for many reasons in drugs because they are always having some renal dysfunction routinely. Second, carbapenem. The carbas are the group of drugs which is commonly used in this kind of patients, and they have the impact of drug variability a lot. And because of this drug variability, the instability may happen, but we use carbapenems as per the patient having the critical care without ECMO as frequent. Now, the vancomycin is a very important thing to be considered here in this topic because there are ample number of evidence, and the literature says that the extracted from the not on of the neonatal group, each age group, the study on that, rather than giving the intermittent dose, given the infusion dose when the patient is on ECMO, otherwise the dilution effect of the ECMO leads to a lot many like variability of the drug. So when we use vancomycin, we should be very clear that we have to give it in the infusion format. Now, if I say the antifungal again, antifungal, as Dr. Murali say that the antifungal ultimately comes in the root of the antibiotic for the longer duration. Now the antifungal has got lot of variabilities because of that lipophilic and protein binding variabilities. If I say the voriconazole has got the lot of variabilities, and for all antifungal, even I just talked about the echinocandins like gospophangins, even gospophangins, they need the because of the lot of variabilities are to be given under the titration. And the guidelines say that, I mean, the data suggested that it should be a dose monitoring or a therapeutic dose monitoring rather than giving empirical. But in our practice, if I just say that, we just partially change the dose, but we don't really go with the tissue, the therapeutic dose monitoring. So antifungal, of course, when we are using, we should be more careful. And the aminoglycosides and like if I say the piperacillin, the azobactam combinations, it is not going to be a change. And more safest drug is the like quinolones. Fluoroquinolones are the more safer drugs which does not make much of the changes when patient is on ECMO. But again, some patients, they have the CNS issues, cardiac arrhythmia, won't have fluoroquinolone quite often, but we use the other drugs which is more sensitive.
No, and how many of us would be really using fluoroquinolones on patients on ECMO, really? I mean, very few would be on
hardly be there.
Yeah. Antiviral drugs also are not really very much affected. So that becomes relevant in the COVID times. So you can continue with the dosages which you're giving. So Dr. Muralidhar, I can see he's joined back again. I hope his voice is back. Murali, can you hear me? Hello? Dr. Muralidhar? No, he can't hear me. Dr. Muralidhar, can you hear me? Never mind. I'll come back to him. And I can see now Dr. Sahu is there. So, Sambit, good to see you.
Yes, sir. Yeah, thank you. But I'm extremely sorry to be late. And I
No
can see
problem,
there's a
sir. I
lag
just
happening
thought
here.
we'll start off with the sepsis, which is the first half of the. So you just joined in right time for the nutrition. I think we all must be getting hungry now.
Yeah.
So evening is coming. So, what are the main
Hello to
nutritional
all.
concerns? What are the main nutritional concerns on ECMO? And does ECMO affect the gut
Yeah.
function?
So that's the primary thing. Does ECMO affect the gut function? It definitely. If specifically if there is a lot of hemodynamic instability and the gut mucosa over time gets eroded, and that leads to a lot of septicemia and bacteremia. And to maintain a healthy gut, some amount of feeds we always try and maintain. Whether it is if the patient is hemodynamically unstable, some trickle feed, some trophic feeds, we definitely try and maintain. And as the patient has, maintain some hemodynamic stability, that's when we escalate the calorie and the protein requirement. And here I would like to emphasize that the protein needs of the patients are hardly met, even in any other critically ill patients, and this needs special consideration, specifically in ECMO patients. Some we might even have to supplement them with added protein requirements to maintain a good muscle tone and muscle power. And this has shown benefit in the during the recovery phase. When the patients are off ECMO, they tend to mobilize faster if the protein requirements have been met, and we have even gone up to 2 grams per day during the late stages of recovery, if not on the early stages.
And the gut function?
And for the gut function, yes, what we try and do, is have some amount of trophic feeds on flow at any point of time, and try and see that if there is a lot of gut stasis, of course, we give some prokinetics, maybe erythromycin, sometimes erythromycin and metoclopramide, etc.
And is enteral nutrition feasible, and is it adequate in most of the studies?
Sorry, I couldn't get you. There was
enteral nutrition.
Feasible. Yeah.
Feasible?
Yes,
and is it adequate?
Yeah, it's definitely feasible, and that should be the idea for any patient who is on ECMO, as in any patient who is critically ill, and that should be the first line. But supplemental nutrition is definitely required. That's where the focus is on, because enteral nutrition does hardly meet the calorie and protein requirements of the patient. So some amount of supplemental nutrition is definitely required in all ECMO patients, all throughout the course of ECMO. That's what we have seen.
Yeah, absolutely correct. See, the gut motility also, the one experimental study has shown, because of the non-pulsatility of the VA ECMO, the gut motility is further reduced. And the GRV, normally we don't pay so much attention to GRV, but probably in ECMO patients, it makes more sense to look at the GRV, to just look at the intestinal motility and the tolerance of. So start with trophic feed, as you rightly said, and then slowly increase. Nothing like the normally functioning gut, because obviously endotoxins also will be less absorbed if the gut is functioning properly. So, Yash, what are the recommended protein and energy requirements in patients on ECMO? Yash, you are on mute. Can't hear. Are you there now? Yash is also got the same disease as Dr. Muralidhar. Muralidhar, are you back? Dr. Muralidhar, are you back? See, I don't want to answer this question because he'll be left with nothing once we are when he comes back. So let's move on. Then I'll come back to Yash when we are at that. So that is Murali Krishna, as rightly said. Last but not the least, I saw him yawning. I think he's been getting bored just listening to us. So I'll wake him up now. Okay, so Murali Krishna, what is the role of parental nutrition in ECMO?
Sir, as been discussed till now, we prefer to have enteral nutrition. All attempts should be made to have an enteral nutrition on flow, and wherever possible, it is enteral nutrition that is best, whether it is an ECMO or non-ECMO patient, which has proved many times. But in a given situation like having need not is like you keep seeing your patient when you at your whatever the targets are not met in the terms of either you're not able to deliver the volume, or instead of giving, you feel there are issues with the absorption, and finally coming it in terms of a body mass, you finally need the final target is not met. On a daily rounds basis, we keep talking to our dietitian or the nutrition therapist, what is the daily requirement, what was done yesterday, how much of it has been met. And once you see coming where clinical or biochemical parameters starts, once you see the patient is meeting the requirement, then you start supporting them. The earliest or the minimal form of parental nutrition I can think of is giving an aminovan just to support some extra protein requirement for the patient. That is what we use. And a total parental nutrition is reserved for very special.
Are you there? So TPN, when you give it, you must have a dedicated separate line. Okay, not in the ECMO circuit, so that the chances of sepsis are further reduced. Dr. Krishnan, are you there? Are you back? Or Yash, are you back?
I'll start answering, sir.
Yash, are you back?
Yeah. Yes, sir.
My question to you was, before we lost you, was what are the recommended requirements for proteins and calories in patients on ECMO?
Sir, yes, sir. Thank you for the question, sir. Determining calorie requirement in ECMO patients is difficult. The use of a metabolic cart to perform indirect calorimetry is just not possible in ECMO patients. And more often, ECMO patients are unable to meet criteria for the best predictive equations, and most of ECMO patients are underfed. Energy requirements, which are based on calories per body weight, are generally used. So what calorie target we generally follow is 25 kilocalorie per kilogram per day, and it is adjusted according to weight, metabolic status, and the inflammatory status. Protein requirement, as Sambit already pointed out, is 1.5, goes up to 2 gram per kilogram per usual body weight, and again it has to be adjusted to the metabolic losses. Especially patients who are also on renal replacement therapy, protein requirement could be even up to 2 gram per kilogram. Thank you.
Also must realize that one thinks that because you are giving rest to the lungs and the heart, patient doesn't have to spend any energy and you can give less, which is not correct. Most of the ECMO patients are catabolic, and even when you are weaning from ECMO, the energy requirements may go up. So one has to keep that in mind when you're giving nutrition to these patients. So Dr. Muralidhar, are you back or not yet? My question for Dr. Murali Krishnan was, are there any nutritional guidelines for ECMO? Any of you can?
There are no specific guidelines specifically for ECMO, sir, but we extrapolate what with the existing guidelines and knowledge are there in the field of the nutrition, maybe from ASPN or all the others, and try to see what all we can apply in a patient specifically with an ECMO.
See, the Aspen guidelines, there were only one mention. One should keep track of, keep in mind that they
True,
should
sir.
not get malnutrition, nutrition should be taken care
Yes,
of.
that's true.
The Indian guidelines, of which I am one of the authors, also mentions that patients on ECMO, they may be nutritionally deprived and their protein and calorie requirement should be taken care of. But that is as little as can be. In fact, several studies on nutrition in ECMO have shown that many of them were not able to reach even 50% of the targets because
Target.
the nutritional, if you're giving enteral nutrition to the patient, few studies have shown almost 70% of the times the nutrition was stopped, feeding was stopped, because these patients undergo procedures, they go interventions. So these are the times when you stop feeding the patients. So that is another problem. And particularly for VA, they may be on high analogs initially. So the gut function may be impaired and you may not be able to meet the nutritional requirement. So this is one situation actually where partial parental nutrition, which is not very common in the mixed intensive care units, becomes more important. The only guidelines which I have published to some little bit is a pediatric guidelines, Aspen guidelines, which have again laid on the emphasis of importance of nutrition in ECMO, but not really more than that in detail. So these are the two aspects which we have ignored over the past, and probably now more emphasis will be paid to this. Is Dr. Muralidhar back in circulation? Not yet? Muralidhar, are you there? No? Okay, the last thing which we need to discuss, which we have missed out in the short half an hour, I think we have a few minutes left, is prophylactic antibiotics. Any of you can come in. Administration of prophylactic antibiotics.
We give only the positive at the time of initiation. Nothing more than that, maybe maximum 3 doses of cefuroxime. And after that, it all depends upon how the patient is, what are we looking, what are the risk factors going. It is not that they necessarily need antibiotics.
See, the ELSO guidelines say there is no need for prophylactic antibiotics. But they themselves in a survey realized that 80% of the ELSO centers were giving prophylactic antibiotics. And they found no difference in secondary sepsis, whether you were on prophylactic antibiotics or not. But by and large, at least for VV ECMO, most of the patients would be on some antibiotics for their primary pathology. So I suppose continue with whatever we're doing. And if the patient is not on gram-positive cover, then at least give a shot like what we do for surgical procedures at the time of insertion of the lines. So I think, Dr. Poonam, our time is up now. We've covered half an hour. We've covered some aspects of nutrition and sepsis, which are both very significant aspects of managing a patient holistically on ECMO. Thank you very much.
Thank you, Dr. Mehta. The take-home message should be very clear, as very nicely summed up. Some small technical mistakes of not having Dr. Muralidhar over should be overlooked because of some connection problems. But I thank each one of the panelists for being with us. I just wanted to put a point forward. Is there a difference between cell wall synthesis inhibitor antibiotics like lanezolid or tigecycline versus protein synthesis inhibitor? I'm speaking the reverse. You have protein synthesis inhibitor antibiotics like lanezolid as well as tigecycline versus a vancomycin or a daptomycin, which is a cell wall synthesis inhibitor antibiotic. These are some of the ELSO guidelines which has just come in, and they are debating which is better. Like you that some of the cefazolines you will not want to use. But sometimes in a patient who's coming on a way, you do start some oral antibiotics. Can you take on that, sir? Because
no, see, linezolid, generally our patients will not be on linezolid because it's a bacteriostatic antibiotic. Same with TG. TG, if we give it for more for MDR organisms, gram negative rather than it has gram positive cover, but and there is no therapeutic drug monitoring in these at all. I mean, so unless the patient has skin and soft tissue infection or MDR sepsis, we will not put them on tigecycline. Linen, obviously now Enterococcus incidence is increasing, particularly vancomycin resistant Enterococcus. So they may be on linezolid. And in that case, you can give tablet linezolid because bioavailability is good. Yeah.
Especially it can be used both IV and oral. So those kind of antibiotics, especially when you're coming off ECMO, they have emphasized in their recent guidelines.
Mm-hmm.
But it was a very interesting new topic on ECMO, and I'm sure there's so much more to do so that we can save our patients from starving on ECMO and sepsis on ECMO. Thank you, one, and thank you all. Thanks to RightDoctors.com for bringing this to us. Thank you so much. Thank you, Dr. Mehta. Thank you so much.